So I wanted to welcome you all. Thank you for joining us. We have a few things to go over today. Let me pull up the slide deck that I have prepared. So mostly what I'm going to be talking about today, the biggest focus is going to be on a study that we have about reducing inflammation in people living with HIV. And we'll be getting to that. But first, I wanted to give you just an outline for what I have. I have announcements, and then I want to talk very quickly about bylaws for the CAB, and then also go through and review not only the study that I was talking about with inflammation, but there are two other studies I wanted to run by you just to get your impressions of them. So first of all, the announcement, and Anne, you'll be happy to hear this. I don't know if you've heard. The first in human clinical trial of a next generation long-acting injectable combination antiretroviral therapy platform is opening. This is a study that Anne helped start, and this is going to be looking at basically the drug levels in the blood over time and the safety of a single injection of a new investigational medicine that combines existing short-acting oral drugs used to treat HIV. So meaning it's going to be a subcutaneous injection of a combination of drugs that already exist to treat HIV, but it's going to be in a new form, in an injection form. So you can see they're talking about lopinavir, ritonavir, and tenofovir. And so this is a study actually that we're opening at our clinic. And we're looking for healthy adults who do not have HIV, no hepatitis B, no active hepatitis C. Eventually, these drugs will be for people with HIV, but when you're going first in human, we are going for a healthy individual because we're just looking to see about the blood levels and how the drug travels through the body. So this is exciting. This has been a few years in the making, and it'll be open now, and hopefully we'll be able to get someone in the study. You might not be able to apply to this study, but I wanted to let you all know that it's open and that we're looking for people. And so if you know of anyone who might be interested in a sort of intensive study, if there's a nice reimbursement involved, it can be between $440 to $1,240 plus another $150 if they get a lymph node biopsy. So especially for someone who's looking to have a little extra cash, we have a few people already lined up, I believe. I hope I didn't get to hear a report if they've actually enrolled anyone yet in it, but the screening for this study has started. Did you hear about this, Anne?
I did. Yeah. And this group has heard about this a long time ago.
Yes.
Because I presented the study or the idea of this study years and years ago. But I have been holding on because I figure once it gets going, it'll keep going. And I just want to make sure it gets going.
Yes, I'm hoping it does as well. It's sort of exciting to...
And no, I think it's really exciting because if it works, it'll change how people are treated. And so that's very exciting.
Right. And so just so everyone understands, this is different than the long-acting treatments that you've heard about, which are new drugs that are being used. This would be taking existing drugs that are taken orally and changing them into a shot form for people to take. And so that's the exciting thing about it. It would be a way of using a new technology to take the medicines that we currently take orally and deliver them in a new way, which would be a way for people, especially around the world, who might have trouble with oral therapies and taking them. So it's an excitement push forward, and it's exciting to be a part of that.
So I can't even remember when Anne presented. But
it's years. Well, I got a grant to do this in, let's see, 2000. So I think it would have been like sometime in 2019, because I think I probably presented this, or it was in 2000. So many years ago.
And to be here still.
Well, I think, eventually this will get potentially applied to more modern drugs and would indeed, if it works, be able to be given by people themselves in their private life, so they wouldn't have to get 2 shots and come to a clinic. So I just think it's quite exciting.
Yes.
It is quite exciting.
Yes, and I forgot to mention that part of it as well, that it's not something that you need someone to administer for you, like as in the clinic with the Cabenuva that we were talking about last month. This is something that would be technically able to be given subcutaneously, either in the belly fat or in a thigh, somewhere where people would be able to administer it for themselves, which is another exciting thing. Anyway, just wanted to let you all know that we're starting that process first, and I think someone's just trying to join us. Let me see. Uh-oh, sorry, hold on. I can't admit people the way that was. All right, let's go back to the screen. All right. And okay, so we were there. You can see the screens again, the slides. Hi, Alistair. Thanks for joining us. All right, so that was the reimbursement.
Hi, Michael.
Hi, and there's the phone number if you have anyone, you know anyone who might be interested in that. It's a study that has just opened this week. So the next thing,
After a long time.
yeah, after a very long time. The next thing I wanted to talk about is that we're being asked to create bylaws for this group. Bylaws basically meaning the rules that we want to agree upon, that we're going to abide by, and yet it'll be a way for us to make sure that when we need to make changes that this group can grow. And it's mostly about trying to establish some sort of stability. In other words, so we don't have to depend upon the seasoned members, meaning the people who've been around for a while, to tell new members how things are done. And so we're being asked to create these. And so I wanted to kind of go through this with us, but not create them now, but talk about doing this. So we have to talk about what makes a member, how someone could apply, what makes a member, what is expected of a member in terms of the responsibilities, things like that. We also have to decide if we're going to have any sort of officers or duties like a CAB co-chair or co-chairs, secretaries, things like that, and how these people would be nominated. We have to decide that. How many meetings we will have, things like that. So we did this once. Oops, sorry. Went ahead too quickly. Where's my tracer? Go back. We did this once for Defeat HIV, those of you who are involved with that CAB. And so we're going to be doing it for this CAB as well. And I have those bylaws that we can use to build upon that. But I was basically going to be asking who might be wanting to work on this with me. And I'm going to send out an email for people to reply. Thanks, Bill. I see your hand. Good. So this will be just something that we can decide. And I'm going to have a meeting outside of this meeting because I didn't want to take up people's time with this issue, because this is not an issue that I find exciting for everyone to have to deal with. But I will be sending out that email, and if you are interested in that, you can let me know that you want to be a part of that. So we'll be trying to schedule a meeting outside of this meeting, so probably within the next 2 to 3 weeks, where we can gather and sort of work out and hammer out some of these ideas so we can have some bylaws, which we'll then bring to the group, and then we can actually sort of vote on them and ratify them that way, or however we want to choose to do that. So those are all there. And Alistair, thank you for saying you're willing to help. I appreciate that. All right. So onward to the subject at hand. We are talking about inflammation tonight. And as you probably know, the chances of cardiovascular disease in people who are living with HIV are higher, and they have all the sort of traditional risk factors like diabetes or excessive abdominal fat or even smoking. All of these are very common in people living with HIV. And furthermore, we know that the activation of the innate immune system can increase inflammation, and it's likely to contribute to this, especially in people who've been living with HIV for a long time. So we're talking about chronic inflammation, meaning that it's when the immune system has been turned on, but it doesn't turn off after an injury or a triggering event. And we don't have yet really a cohesive way to measure inflammation yet. But what we do look for are inflammation markers or chemicals that are released during the process of inflammation. And so those markers, some of them, just so you know, C-reactive protein, D-dimer, fibrinogen, interleukin-6, and interleukin-8 are some of those you may have heard of. But so when we're talking about lowering inflammation, what we're often talking about is lowering these inflammation markers. And so inflammation, as you probably know, it's linked to just about every bad thing that can happen to us. Cancer, heart disease, liver and kidney failure, dementia, autoimmune diseases. And it's one of the reasons that we think that we see higher rates of cancer and as well as heart disease in people living with HIV. So we're not completely sure why people with HIV have chronic inflammation, even when their viral load is under control. So there's some thoughts to it, but we don't have any sort of solid answers, although we're looking for them. So it could be that there's ongoing viral replication at a low level, even though you're on antiretrovirals and even though you are undetectable. It could be that the immune regulatory cells become dysfunctional. It could be something that we call the leaky gut syndrome, which is basically when the microbes translocate across the gut's barrier, and that might be actually the cause of some of this inflammation. It could also be the cause of another viral infection. If you remember, we were talking about viruses like CMV also adding to inflammation, and we've done a talk on that. So it could be the presence of other viruses, and it could also be that your thymus is dysfunctional. But we're not sure why people with HIV have chronic inflammation. We just know that it is happening. And so if you're worried about inflammation, there are things that you can do, and I just wanted to review this very quickly. Smoking is one of the easiest things, but yet the hardest things to quit, but it's one of the surefire ways of lowering inflammation. Paying attention to your diet, paying attention to eating fruits and vegetables, as well as not having so much refined sugar in your diet, getting plenty of exercise, maintaining a healthy weight, cutting out recreational psychostimulants. We know that cocaine, methamphetamine, and ecstasy all can raise the inflammation, especially in the brain. And the other way to keep inflammation in check is to make sure that your HIV is well controlled. But besides all of those things, we obviously still need to do something because people living with HIV seem to suffer from higher rates of inflammation and the results of that having higher cases of heart disease and cancers. And so we need some other way of working on inflammation. And so that's what we're going to present here today, which is a new study that we're looking at, and we're going to be opening here in Seattle. It's basically a study of this new drug called cenicriviroc, and it's cenicriviroc mesylate, and we want to see its effect on inflammation in people living with HIV. The number of this study, according to the ACTG, is A5415. So cenicriviroc mesylate is an oral pill, and it was previously being developed as a therapeutic agent for HIV, but then another company bought out the company that was making it, and they started to use it for liver disease, especially in terms of liver fibrosis with NASH. And the drug does inhibit inflammation in fibrosis, and there's been plenty of studies in people with liver disease that shows us that this drug works for that condition of inflammation and fibrosis. And so, for our intents and purposes, cenicriviroc is hard for people to say, so we're going to call it the CVC study here. We're just going to use that abbreviation, and you can feel free to just call it CVC as well. So this is one of the outreach materials that we'll be having for this study here. You can kind of see what it looks like. And we're looking for people who are undetectable, who have cardiovascular risk factors, and I'll be going over those. So
I have a question.
Go ahead, sure.
What is NASH?
NASH is a stage of liver disease. It's before you get to the non-alcoholic fatty liver disease. And I can't remember what NASH stands for, though, Bill. Ann, do you remember what NASH is actually standing for? It's like non-alcoholic.
I think it's steatic, and then I don't remember what the H is.
I can't remember it either. Yeah. But it basically,
it's steatohepatitis.
it's what?
it's non-alcoholic steatohepatitis, I
Oh,
think is what NASH is.
Yeah.
It's in the chat with some creative spelling.
Is it? Okay, thanks. Take a look in the chat there with some creative spelling. Thank you for that. Yeah, there you go. Cool. Thank you, Mark. So don't worry about the spelling. That's great. So that's what the drug has been used currently for. And so we know that it inhibits inflammation. And so what we want to now do is apply this back to HIV, but not as a therapeutic agent necessarily to treat your HIV, but to help treat the inflammation that is associated with HIV. And that's what makes this a kind of an exciting thing. So we really believe that this drug treatment will reduce inflammation of the arteries, especially in people living with HIV. And so the purpose of this study is to assess the changes that will happen in terms of your metabolism, like your fasting blood sugar levels, and as well as the overall blood or your overall inflammation throughout your body. But we'll be looking specifically as a measure, we'll be looking at the arteries, especially the arteries in your neck. To show that. So the study is going to be taking participants and randomizing them, which is like flipping a coin, and it's going to be a 2-to-1 ratio, either to take CVC or to get the placebo, and it'll be something that you take by mouth once a day for 24 weeks, in addition to whatever HIV medicines you are currently on. So it's only about a half a year, 24 weeks. And the randomization will be stratified by the current use of statins or none. So in other words, not only are we going to be separating people into two different groups, we're going to make sure that statin use is looked at, because statin use might be affecting the results of this. So I have a next page here that'll show us what we mean. So we have 93 participants in the study with a 2-to-1 ratio of being enrolled. So that means the arm A that's going to get the CVC is going to have 62 people in it, and they're going to be stratified as to whether they're on a statin or not on a statin. And then it's going to be compared to the placebo arm, which will have 31 people. And again, that'll be stratified to statins and no statins. So they're going to be trying to make sure that they look at all those combinations within these two groups. And again, that'll be going on for about half a year or 24 weeks. And so that's the easy part of the study. It's basically just adding an oral medicine to what you already might be taking as an HIV medicine. The requirements of the study, you have to be at least 45 years old and on a stable regimen, but you'll notice that there's no cap on that in terms of how old you can be. In other words, there is no upper age limit, which is a nice thing to see. So this is looking especially at people who have been living with HIV for a longer time. Usually people who have aged that way for a while have more inflammation, and so we're looking for them. We're looking for people to be undetectable for at least a year, and they need to have one cardiovascular risk factor, which I'll be going over in the next slide. They're also going to be asked to take a PET/CT scan, and that's going to be something that you can get through the study, but you'll have to do it 60 days before you enter the study. And if people are of reproductive potential, they can't plan on becoming pregnant during the study, or they have to be willing to use contraception. We need to make sure that their body weight is less than 300 pounds. There can be no active or latent tuberculosis, no untreated hepatitis B, and no current hepatitis C virus, although they could be successfully treated for hepatitis C at least 6 months before the study. So what are these cardiovascular risk factors? Well, so here are a list of them for you. Atherosclerosis, which is the plaque buildup in the artery wall and the narrowing of your blood vessels. Diabetes or pre-diabetes or an impaired fasting glucose or insulin resistance. Being diagnosed obese. Having a history of hypertension or blood pressure that's over 130/80. Also having a low HDL cholesterol, which is the good kind of cholesterol, or like we call is the good cholesterol. And what we mean by that is that HDL clears from the body via the liver, and so it kind of prevents the buildup of plaque. It helps protect your arteries and then protect you from atherosclerosis. And so that's why we consider it to be the good kind of cholesterol. So if you have low levels of that, that is one of the cardiovascular risk factors they're looking at. Also, obviously, if you have the elevated LDL cholesterol, which means it's a bad form of cholesterol, if you smoke, you're eligible. And if you have a family history of had or coronary artery disease, and that is basically plaque buildup in the walls of the arteries that supply blood to the heart. And if you have a family history of that, so it means if you're, it has to be a first degree family, so your father or mother have that age to, they got it basically before age 55, and for females, it was before 65. And the last one is one of those inflammation markers. If you have a high reaction to that marker, and this marker of inflammation is the one that they use to predict your chances of having a heart attack or stroke or peripheral arterial disease or sudden cardiac death even. So those are all the things that they'll be looking at in terms of having a cardiovascular risk factor to join this study. So the PET scans will be required of people, and you'll do one before you enter the study, and then you're going to do one at week 24 at the end of the study. Now, hopefully you'll be able to do it once, but there's a small possibility that the scan may need to be repeated if they can't evaluate it, but it'll only be repeated at most one extra time. Now, you might not know what this FDG PET scan is, and so I have a little video lined up for us to be able to look at what to expect from that.
PET-CT combines two different imaging technologies in a single scan: positron emission tomography, or PET for short, and computed tomography, or CT. Together, they result in a highly sensitive test that allows physiological changes to be precisely localized and evaluated at an early stage. PET measures the body's biological processes. CT generates high-resolution cross-sectional images of the body's anatomy. By combining both sets of information into a single, three-dimensional image, metabolic processes are mapped precisely and in all spatial dimensions. This helps to reveal the patient's condition at a very early stage. The combination of PET and CT gives a more accurate picture than the two scans performed separately, helping to facilitate a more accurate diagnosis. Physicians use PET-CT scans to aid in the detection of tumors and metastasis. Scans can also aid in distinguishing between malignant and benign changes at an early stage, determining the stage of a disease, developing a treatment strategy, and monitoring the response. PET-CT scans can also be used to evaluate Alzheimer's disease and heart disease. Metabolic activity is measured using so-called PET tracers. These are weakly radioactive biomolecules that behave like normal biomolecules and accumulate where needed. The PET scanner records an image of the tracer distribution as it collects in areas of higher metabolic activity, similar to cars gathering in a parking lot. These areas show up as bright spots on the PET scan. In principle, any biomolecule can be a tracer. Most often, however, radioactive labeled glucose is used, so-called 18F-FDG, which accumulates in tissues and organs with a high energy demand. Since the tracer decays quickly, it must be prepared anew before each examination. Before the PET-CT scan, the tracer is injected into a vein in the patient's arm. After that, the patient must rest for an hour to allow the substance to spread through their body. Then the examination takes place. CT uses X-rays and images multiple layers of the body in succession. The PET scan registers the decay of the tracer by means of the gamma rays emitted. A fused image is created from the dataset. (18F-FDG) glucose has a short half-life. After 2 hours, only half of the radioactivity remains. After 4 hours, only a quarter, and so on. The radiation dose from the two examinations corresponds, on average, to the annual natural background radiation, to which every individual is exposed. At present, PET-CT scans are used to make mainly static images of the metabolic processes. The future will be dynamic imaging, that captures and quantifies the metabolic processes over time. This will give physicians additional information to be able to diagnose, stage, treat, and monitor disease more effectively.
And that hopefully gives you an idea. Oops, come on. The last thing that we're going to be asking from people in this study is that they're going to keep a four-day food diary at the beginning of the study or at the pre-entry, and that'll be collected from them at entry, as well as at the end. They'll be given it at week 22 and collected at week 24. And so that is the study in a nutshell. Do you have any questions?
How is success going to be determined?
Success meaning the lowering of inflammation. Well, that's what they're going to be measuring with those PET scans. They're going to be looking to see if there's been any sort of influence on the plaque buildup in the arteries. They'll be looking at the metabolic changes that have happened to see if that it's lowered the fasting sugar levels in the body and things like that. So that's why they're doing the PET scans, and they're going to compare the before, which you're going to get the PET scan before you entered the study, and then the one after the 24 weeks of taking CVC.
Hmm.
And that's how they'll measure like if it was successful or not. Any other
Have
questions?
they decided if that medication has what side effects it has?
Yes, they have used it a lot in a lot of people, especially because they were using it for liver fibrosis. And so there have been very few serious side effects that have happened as a result of that. And I don't know the actual side effects off the top of my head. I forgot to get that part down. But there was nothing that was giving anyone concern about the side effects of the drug. So that's why they have some hope for this in terms of this study, because it seems like it'll help with inflammation because they have evidence that it does with other people in other situations. So we're hoping that for HIV-associated inflammation, it will do the same thing.
Michael, can you put up the inclusion criteria again, please?
Sure can. Hold on.
Thank you.
There you go.
So can I ask a question? When
Sure.
you say at least one cardiovascular risk factor, people can have more than one?
Yes. They have to have at least one, but they can have more than one, which often goes, I think, hand in hand with cardiovascular risk factors. And that, do you want that next part up, Alistair, or did you want this part? Because the next part was this part, which was going specifically about those cardiovascular risk factors.
Actually, I just wanted a refresher of the
Sure.
inclusion criteria.
Sure.
And then if people have seen enough of it as a repeat, if we could then see the exclusion criteria of any.
I've kind of blended them here. So you'll see like the exclusion criteria is towards the bottom there.
No latent, no untreated. Yes.
Yeah. Basically, they can't have tuberculosis, no untreated Hep B, or no current Hep C, but they could have been successfully treated for at least 6 months prior to the entry. Also, one of the exclusion was the being over 300 pounds. And so we wrote it just being, body weight has to be less than 300 pounds there.
Okay. Now, in terms of the TB, is that going to be determined by a TB test?
Yes. If they're not sure, that's how they would determine it. Yes.
Okay. If somebody has the TB test, the subcutaneous one,
Mm-hmm.
or the skin test, and it potentially is reactive, will they then get an X-ray to make sure that they either have TB or don't?
I'm not sure if as a part of the study this would happen, but I know, for instance, here, that would be like if we gave the TB test and it came back positive, we'd be referring them back to their primary care for the treatments that they would need to get further to that. You know what I mean? I don't know if the study itself would be taking care of that, but
No,
definitely.
I'm raising that because
Yeah.
back when I was working full time for
Right.
UCLA Med Center, my TB test, the annual TB test,
Yes.
with the skin test would show positive, and then I'd have to get an X-ray, which wouldn't find anything. So I don't know if that would be sufficient, for example, to exclude me from this particular study.
Ah, I see what you mean. I do not know the answer to that. I'll have to find out for you.
Okay.
I'm not sure
I
about
don't think my case is particularly common,
right.
but since I've experienced it, I figure I'll raise it as a potential.
Yes, no, that's great. I'm glad you do. Were there other questions that people wanted to ask?
So, Michael, if you have high blood pressure, but it's you're taking drugs for it, and it's now normal, does that mean you still have that risk factor?
I would say yes. Let me get to that. Where is that? Yeah, here. So right here where you're saying that you have so it's a history of hypertension or high blood pressure 130/80, and it's either equal to that or greater than that.
It is not now, but it has been in the past.
Yes. Yes. So that would still make you qualify.
Okay.
You know, like the same thing, like if you have diabetes, but you're treating it, it still would mean that you could qualify for that because they're concerned about the inflammation that's creating the situation. And Manuel, I see your question about the number of sites. I'm not sure about the number of sites that have signed up for this one, but this is an ACTG study, so there's more than one. I know I've already seen like San Diego's doing it as well as Cleveland. We'll be opening it here, so I'm sure it's going to be a lot of places that are doing it. The barriers to enrolling into this study don't seem to be very high. So in other words, I expect that this study would be an easy one for people to enroll. And so I would assume that many sites will be doing it. But that's just an assumption on my part.
Do
seeing any-
a lot of sites have FDG PET, or is that like
That's
a pretty sophisticated thing?
Yeah, I think it sounds pretty sophisticated. So I'm not sure about every site having that. I can find out about the number of sites, but you know, based on what I learned about the PET CAT scans there, it really seems like they need to have those because that's going to be a major part of the study in terms of the diagnosing whether this treatment works in people with HIV. So we'll need to have that. I'm not sure about other sites. Go through here, skip along. Nope. And so just to share with you, here are some of the advertisements that I've created for this. We have lots of different people that I've pictured. This is just giving you an example of two of them. I also have a QR code for people if they want to contact us that way, or if you can see, I kind of chopped it off here, but underneath this would be a tear off sheet. So if people just want to tear it off and want to use their phone to call us or text us, they can do it that way as well. But these will be going up around town surely soon enough.
Are you comfortable emailing those to us?
Yes. You want the materials emailed?
If you could, please.
Sure.
I can check with the local sites here to see if any of them are likely to be doing it.
Okay.
A brief use of Google says that Cedars-Sinai can do it.
Mm-hmm.
So I suspect that UCLA and USC should be able to do it.
Yes, I
So
would
there's
hope so.
a fairly good chance that there's a Los Angeles.
Yes, that'd be
potential.
great. Yes. So those are there. Up, Rachel is joining us. And so let me ask you all. So did you understand the study? And you can just either type in the chat if you want to put yes, or if you want to say yes verbally, or no, or do you think this is answering an important question for people living with HIV?
Yes, I think inflammation is really important.
I think so too. And how about this? If you were qualified for the study, would you be participating? Would you want to
Yes.
participate in that?
Most likely, yes.
Yes. Cool. I like that fact that there's no upper range limit, so people who often are excluded because they're over 65 or over 70, they won't be excluded from this. And do you think that the potential benefits of having your inflammation treated would be of interest to potential participants?
Definitely.
Good. Yeah, I think so too. Go ahead, Richard. You had your question. You had your hand raised.
No, I was just indicating that I was interested. I'm sorry.
Got it. Thank you.
Well, as much as I've complained about not being able to get into studies, it seems like this was tailor-made for me.
Uh-oh.
And, I've had many discussions with people on inflammation and the real problems that they cause. And as you were going over that list in the beginning, I kept thinking, that sounds like me.
Yes.
And so it really would behoove me to sign up for this study. I think I would be doing a disservice to myself if I didn't.
Alistair, I see you had your hand up.
I put my hand up for a couple of reasons.
Sure.
One is because I have taken part in a whole boatload of ACTG studies since last millennium. And I can definitely recommend them as a good way to find out about, in my case, my own health conditions, my own peculiarities in my blood work. It's a good extra opportunity to have things checked that a normal checkup at the doctor wouldn't find. So I can definitely recommend that if somebody is even slightly interested in that information, it's a good place to go. And then the second thing is, I know I didn't notice it mentioned, but I am currently in the Reprieve study.
Right.
And that's being studied to see if someone who doesn't need a statin for inflammation or for high cholesterol can benefit from taking it as an anti-inflammation mechanism.
Right.
And is there anything that would prevent somebody who is already in the Reprieve study from taking part in this one? Or sort of vice versa? Would the Reprieve folk perhaps be a little bit unhappy about somebody starting to take CVC?
Right. That's a good question. And I'm not sure of the answer. I don't know if, Rachel, I know you've signed on. I don't know if you have an answer for that question.
Here, I believe that Reprieve, it's a lot of protocols you can co-enroll with Reprieve, but I think not if you're still on study drug, just because they don't know. But let me go pull the protocol and I'll try to get you an answer.
And I was going to say, there's one thing, Alistair, I do remember from reading in the protocol was that there were certain statins at certain doses that were not allowed.
Okay, the Reprieve one, I believe, is pitavastatin?
Avorvastatin.
Sorry?
Is it avorvastatin or is it?
Pitavastatin.
No, I think it is pitavastatin.
Okay.
4 milligrams of pitavastatin. Yep. I will get back to you on that. Let me just look.
Okay, great.
Pitavastatin is one of the newer ones.
Right.
Atorvastatin is one of the older ones.
Older ones, right.
So one of the reasons I was willing to get onto the Reprieve study was I didn't particularly like what I was reading about atorvastatin.
Right.
But it looked as though pitavastatin didn't have some of the potential for unfortunate side effects. So I was willing to get onto the Reprieve study, and I've been on it for years. So it's a long-term study.
It is. And so we'll find out about that. But I know co-enrollment, and Manuel, I see your question there as well about are people able to participate if they're co-enrolled in another study, even if it's not reprieve? And I think it's about whatever the study drug is in that other study, if there is one that is being done. So I think it would be a by case by case sort of situation. But we'll find out from Rachel when she has an answer for that. And so, go ahead.
Since Rachel is able to look these things up, is Rachel able to tell us the sites, the other sites?
Yes, sir. There are 15 sites. Again, I'm in the middle of looking up that other question.
No, I understand that. I just wanted to find out.
Yes, it is a site-limited study, and there are 15 sites, and we weren't originally one of them, but I nudged our way in because I knew that it would be important to you all.
Well, thank you, Rachel.
Yay, Rachel.
While Rachel's looking stuff up, do you want to continue through these questions?
Sure. Well, I was just going to say the last questions that we have here. Do you think that there's anything in this study that would discourage someone from a specific group, which could be women, men, people of color, people over 50, IV drug users? Do you see anything like that? People under 18, obviously.
This is one of the more irritating questions in the questionnaire for ACTG studies.
It is.
In that very frequently, one of the questions they give as examples is explicitly one of the exclusions.
Exactly.
Because you have to be over 45.
Exactly. So, of course, it's going to be letting people like that out, you know.
Yeah. And didn't you say something about contraception?
Yes. Yes, people have to be willing to use contraception if they're childbearing potential.
Presumably because the potentials for problems with fetal development are unknown.
Yes.
Yeah.
That's correct. Although, I mean, to be totally honest, we have other studies like Latitude that require people to have contraception, and I think it's just because it's not about the actual risk to the pregnancy. It's about trying to, or for example, the Do It study. And I think some of it is just navigating pregnant participants on study. And I think honestly, like we need to push back a little bit more about, I mean, not necessarily people who are pregnant at study enrollment, but the possibility of becoming pregnant. Mm-hmm. Because I think that it just, I think that if there isn't really a safety concern, then the study should be able to deal with it. It's sort of, there's a lot of regulatory consequences if somebody becomes pregnant on study and the reporting and the following and all the safety follow-up for that. But I personally feel that for studies in which the intervention is standard of care ART and all of those drugs are approved and authorized or have data for pregnant people, I think that that's sort of a little bit silly. But to be totally honest, for Latitude, I don't think we have good pharmacokinetics in people who are pregnant. And so is it probably fine? Probably. Do people get pregnant in clinical care who are taking that medication? Yes. Yep. Would we consider switching them to a different ART regimen that had more data in pregnancy? Probably.
I was actually thinking more in terms of something as simple as the FDG being a radioactive tracer. That might be considered something to make them reluctant to have anyone pregnant or about to become pregnant in the study.
Yeah, I mean, I think that is, you certainly, I think, would definitely have pause of doing a PET scan in somebody who is pregnant. I think there's different ways that you could do this. You could say, we're going to make sure somebody has a negative pregnancy test at enrollment. We're going to do another pregnancy test before they get a PET scan and just not get the PET scan if they were pregnant. Yeah. I think the other issue is if you're looking at endpoints like inflammation and weight gain and change in all these things would be completely uninterpretable if somebody became pregnant on the study. But I also think that, it's probably a pretty low risk unless somebody comes in and says, I'm intending to get pregnant. Right. There's a difference between intending to get pregnant and not intending to get pregnant and having a low chance of getting pregnant. But anyways, that's a little bit of my soapbox about.
Is this the first study of its kind?
What do you mean the first study of its kind?
Specifically, the first study with CVC
No.
and involving the PET FDG scans.
There's been a study in people without HIV.
Yes. And there's been studies in people with liver fibrosis where they have a lot
Who
of
had who had HIV?
um
Who did not have HIV.
right.
So, Rachel, were you able to see whether
Mhm.
reprieve is an exclusion?
Yeah, co-enrollment guidelines. We are encouraged to co-enroll people on 5128, which is the stored specimens one, and biologic samples. Co-enrollment is not allowed with reprieve.
Probably because you can't unblind reprieve, I bet.
I think that's what it is. Concomitant medications, just in terms of the statin question. So you're not allowed to be on a high dose statin because the idea is that it's high dose statin would be a different mechanism to try to attack inflammation. And so a lot of the prohibited medications would be like people who are taking high dose systemic steroids. So if somebody's taking like a steroid inhaler, that's fine, but not taking a high dose steroid or taking medications for lupus or things like that. That would be altering inflammation. And then statin dose would be greater than 40 milligrams of atorvastatin or greater than 20 milligrams of rosuvastatin. I think if somebody is on such medications, before the screening period, somebody could have their dose back down if that would be clinically acceptable. Like, so for example, if somebody was on a higher dose statin and hadn't just had a heart attack or a new stent put in, and their doctor felt like it was appropriate for them to be on a lower dose of statin before the screening period, that would probably be fine.
Mm.
The other consideration about potential for pregnancy is since they're not taking anyone who's not over 45,
Right.
that shouldn't necessarily be a big problem for people that are likely to be interested. Since age 45 is quite a high age for a woman getting pregnant.
Exactly. For this study, I think that's a great point. For this study, it's not a huge thing. It's more like I also have been advocating across different studies to be more permissive on how strict contraception needs to be in contraception language around for interventions in which there's no or very little risk to the pregnancy of the intervention.
I do suspect, though, that the changes during early pregnancy and then middle level pregnancy are likely to be quite confounding to a study like this.
Yeah, exactly.
Mm-hmm.